That's I think eventually what's going to become a myopia specialist, myopia control specialist, is going to have to be a binocular vision specialist. So I think the separation of functional binocular vision from what the rest of what we're doing is connecting. It's not getting further apart. It's actually going together. And despite the fact that there hasn't been any findings so far that's shown a direct correlation between those two things, I see it nonstop in my practice all the time. Give you an example. We have an Ortho-K patient starts in their progressing myope, and they have other kinds of issues going on. They might have ESO, they might have EXO, might have accommodative facility, they might have a giant lag to go on. When I finish my Ortho-K on that patient, they're fine again. I've corrected that vision problem with Ortho-K. I've straightened most of those issues out. You know, that's a free ride for me because it means that I didn't have to do VT or other things on that patient. With these other modalities, other than MySight, which actually provides, again, the additional plus, which which will help, they'll help with the near point. These other modalities with low dose atropine, with the spectacle prescriptions, are not going to make this easier for the child to do their work. Okay. And unless we address those near point problems with solutions for them, we're not really solving part of their problem here. We're creating more issues for them. In fact, it might even impact their learning. So we have to really kind of answer that question as well. And I know this has been, we started out with this thing back in the 1980s and everybody said it's all genetics. Myopia is nothing but genetics. And now we find out that, what did that mean? That was a free ride for all of us because it meant nothing, no matter what we did, they're going to get more nearsighted. Now today, we turn that whole thing around to the other side, and now we're aware of what we're doing to a patient will have an impact on how they progress in their vision. Will have an impact on how they learn. So I'm throwing this out there. I think that the research I've seen, the research coming out of China is very fascinating. We're going the other direction here. We're going to have to, the one thing that bothers me is that most of my colleagues don't do near point testing, don't do dynamic retinoscopy. They don't even do retinoscopy. That's like that's like an MD doesn't use the stethoscope. That's not how they use that instrument. So I think, to be able to understand what this patient is going through, I think we need to do this near point and functional vision testing. And I think that's the only way we can really understand what we're actually doing to the visual system when we prescribe this particular device, when we put atropine on their eye. What is that doing to their accommodative facility? So until that begins to happen, and it's actually great news for everyone who's really concerned, because it means that they're going to really be able to separate themselves from everyone else who's just going to, no follow-up, just going to prescribe a spectacle lens. It means that there's a lot more work to be done here, until the job is done. We're not even that far along in this journey that I began in the early 1980s.
Yeah.
Can I follow up on that? I have a quick question. You mentioned that Ortho-K fixes your BV issues. Can you elaborate on that?
Yeah, it's fascinating because, like, you'd have a patient who's had a lousy accommodative facility. You can't focus. I mean, the PRA and NRA, and you finish the Ortho-K part, and it's back to normal. It's back to which they've never been at before. So it fixes those kinds of accommodative issues, and likewise with the convergence issues that go along with that, with your ACAs and everything else. Most patients, I should have published these results because I did this on all my patients. I found out that magically I'm fixing their binocular issues. Take a look yourself. I would encourage doctors here to do the testing and do it post, pre and post, and see what happens to their visual function. It improves dramatically, and I think that MySight has a solution here that I'm comfortable with because of the plus that it gives a patient, right? Because that's going to help a lot of facility patients. So I don't have any problem with that.
Your theory? Is that your theory about how it works? Is that it's the outer plus that helps with?
You mean in Ortho-K or any kind of use of plus?
Or MySight, yeah.
I have found out that my dad grew up with plus a halves. I mean, they used to say that, this is the guy just trying to sell a pair of glasses, right? Or that this is smoke and mirrors, that they used to criticize him. His colleagues used to criticize him. Well, that plus a half a lot of times corrected these issues binocular issues he was dealing with. So plus and more, I don't know about you guys, but I found in my life, patients come in, they want to see they tell you they want to see distance. They don't want to see distance. They want to see near point. That's what they're doing all day. And plus, they need more and more of it. You can facilitate, however you facilitate that into the prescription, it's a good idea to do that because it's going to ease their symptoms tremendously. The challenge has always been to grow more of our colleagues, into this frame of mind to take better care of their kids. So, I mean, that's where we're at today. It's what do we face as far as challenges of the future? We face exactly this. But there's not enough of us around. Okay. We need to have more and more of us doing this thing and being concerned and taking care of our patients properly. And, that's something we all need to work on.
Yeah.
And having that binocular vision perspective, I think you're totally right. I totally agree. The more I've gotten into doing vision therapy and the more I understand vision on a more profound level, the more I'm like, this is a tool and it can help these people, but we need to get more to the root cause of why they're having these problems to begin with. And as we start addressing the root cause, we might actually find that we can slow down myopia without actually doing anything because we address the right issue, right?
Yeah. Yes, exactly.
It's that preventative care mentality.
Yeah. And we're going there. It's taken us a while, but you can see where the wheels are coming. I can see where it's going. So I think that's where we're going to head it up here. So,
yeah.
If you're interested in getting the rest of the episode, consider becoming a paid supporter of the Myopia Mindset. In addition to an extended version of this episode and every other episode that we do, you'll also get access to exclusive monthly bonus episodes of the Myopia Mindset. And I know you're interested. You've made it this far. You can do so on our Substack, myopiamindset.substack.com. I'll see you at the next one.